Basically, remember the picture of the lymph node that I showed you? This is why the picture's in there. All it really is, these all arise out of a lymph node, not out of the bone marrow. Depending upon, marginal zone lymphoma, it arises in the marginal zone. The follicular lymphoma arises in the follicle. All right, what's the difference between them? They come from different spots. Some of them are a little more aggressive than others. These are definitely more aggressive than CLL, which is the one we talked about first yesterday. Basically what we see here, follicular lymphoma, we see an increase in small and large cells, so we don't have that homogeneity that we see in CLL. Remember we talked in CLL, it's pretty much little clones. It's like all of the lymphocytes look very, very similar or identical, okay? In the follicular, in the nodal, or in the lymph node lymphomas, we'll see a mixture of lymphocytes and shapes. Some of them will have a cleaved nucleus. Some of them are called cerebriform, where it's supposed to look like a brain. Those who aren't as big of brainiacs and are a little, have less kindness, call them butt cheeks, because that's kind of what they look like. So we'll see a variety. Some of them look like flowers. I have a lovely slide of a body fluid that's full of lymphoma cells. It looks like water lilies. It's very pretty, and I thought I could blow it up, put it on the wall, and nobody knew what it was. It's beautiful. We see a difference in our cytogenetics and in our immunophenotyping, and I've got a chart at the end that kind of puts this all together. I'm not going to ask a ton of questions about the noble ones. Our aggressive B-cell lymphomas. The problems with these is just, as it says, they are aggressive. They infiltrate everything. They grow in a very diffuse pattern, which means they kind of show up everywhere. They're common in both children and in adults. They frequently appear as tumors. Okay, and these are not usually leukemic, they're not usually circulating. These tend to appear as large tumors, which will eventually invade the bone marrow and possibly the peripheral blood. We'll see centroblastic or immunoplastic cells, again, just what they look like. The most common of these is Burkitt's. And Burkitt's lymphoma, they say when you look at the lymph node on the microscope, it looks like Starry Night by Ruth Van Gogh, I think, printed it. Okay, I don't see it, but maybe the pathologists do. But what we have here, this is how it presents. It doesn't usually present as a systemic type thing. It's generally a large, solid tumor.
Is that a kneecap?
This is a kneecap, this is an ankle. Yeah, this is a very unhappy child. It does present as tumors. It is very characteristic in the way it looks. The way it looks to me, yes, it has these vacuoles, but to me these vacuoles are so they looks like somebody took a hole punch and made holes in these. Not only do we see these vacuoles in the cytoplasm, but notice we even see them within the nucleus. These are they're not actually vacuoles, they're holes. So we have these holy cells, and they make these horrendous tumors. They used to be classified as L3. They were previously classified as acute lymphocytic leukemia. But the cells really aren't blasts, they're mature, they're just really weird. And because they present as solid tumors, remember I told you when we were first talking about it, WHO, FAB used to classify only leukemias. While in WHO, they took the leukemias and the lymphomas and kind of wrapped them together because they really are the same thing. They're a lymphocytic neoplasm. So whether it's presenting as a solid tumor or whether it's presenting more as a liquid tumor in the bone marrow and circulating, it's still the same thing. It's still cancer of white cells. So they kind of put them together into one classification system. Basically, if we look here, we're looking at markers for the B cell neoplasms. CLL, the thing here that we're looking at is, okay, almost all of them are SIG positive, which is surface antiglobulin. Okay, the only one that's not is plasma cell myeloma. Our CLL is going to be CD5 positive, and so is our mantle cell. So to differentiate those two, I've got to go down here to cyclin D and to CD23. So my CLL is going to be surface antigens, CD5 and CD23. I'm going to differentiate that from mantle cell because my CD23 is going to be negative. Okay. I really don't think I would ever ask you any of these marginal zones as far as the markers are concerned, because they just don't have a ton of them. Hairy cell, what was the thing that you need to remember about hairy cell? Which stain is it that's positive in hairy cell? No, it's not up here. Which stain is positive in hairy cell? Because this is the clue that's almost always on the boards when it comes up.
The trap?
Trap. The trap stain is positive for hairy cell. The other thing that is positive for hairy cell is 103.
You say it's always positive.
Yes, trap is always positive in hairy cell. And CD103 is always positive in hairy cell. Those are the ones you really should remember. CLL or SLL, surface immunoglobulin CD5 and CD23. Remember that, it'll be on the test, I'm telling you. Hairy cell, trap stain, and CD103. Pretty much, I think that's the only ones I would ask the surface markers on my test. Does that mean they won't be on the boards? No, it doesn't mean they won't be on the boards. But for my test, if you can remember 5 and 23 for CLL, 103 and trap for hairy cell, and I think that's about it. And that maybe our B cell, our large B cell lymphomas, we look at a BCL6. That one might or might not show up. But this does show the importance of these CD markers. It's how we look at these. This one here and these look very similar. We can't tell them apart morphologically. They also look like monos. I believe this is the one, we had a patient came in and we called them monos, 40-some% monocytes. We sent it out for cytogenetic testing, and the next day we started calling them lymphocytes because they were lymphoma cells. But they looked like absolutely picture-perfect monocytes. They had vacuoles, high NC or low NC ratio, fine chromatin, lobulated nucleus. Sure looked like a mono to me. Looked like a mono to everybody. Looked like a mono to the pathologist. And we got the CD markers back, and we all changed our minds. All right, mature T cell and natural killer cells. B cell neoplasms are bad. They're not a good thing to have. T cell and natural killer cell neoplasms are very bad. Very, very bad. You don't want these guys. They're extremely aggressive. They are fatal, usually in a relatively short time. Remember I told you CLL, you can live with it for many, many years. These not so much. They luckily are less common than our B-cell neoplasms. CLL is the single most common leukemia that we see. They are more common in adults, and they are significantly more aggressive than our B-cell neoplasms. A lot of times we'll see organomegaly. And what's organomegaly again?
Inflammation of organs.
Enlargement of the liver or the spleen. What's kind of interesting about several of these is they'll have skin lesions. If you've ever seen someone who has psoriasis that has the big plaques on it, they'll be similar looking to that. It almost looks like they've got a scaly something growing on them. As a matter of fact, when we go through one of these, they call it mycosis fungoides because they thought it was a fungal infection when they were first diagnosed many, many years ago before we had a lot of what we have. They thought it was fungus, and it turns out it's not. It actually is a T-cell lymphoma. Aggressive natural killer cell leukemia is associated with Epstein-Barr and autoimmune. What is Epstein-Barr? What does it cause? Mono. There are several of these lymphocytic lymphomas and leukemias that are associated with Epstein-Barr. So just a simple little case of mono may lead you to nastier things down the road. Basically, large granular lymphocytic leukemias, we're going to see these are T-cell variants. We're going to see CD3 positive if they're T-cell. We're going to see CD16 and 56 if they're natural killer cells. Okay, so how can I tell the difference between the two? Because they look the same. I'm going to have to do immunophenotyping. Our cytogenetics will see a clonal rearrangement in T cells, but the natural killer cell leukemias don't really come up with anything on the cytogenetics. They don't seem to be genetically driven, they just sort of run amok. Adult T-cell leukemia or lymphoma, basically we'll see a disseminated neoplasm of mature CD4 T cells. It is associated with retrovirus HTLV1, and we find it in the Caribbean, Central Africa, Southwest Japan. Why it's there, I have no idea, but that's just where we tend to find it. We'll see a leukemia with generalized lymphadenopathy. Skin erythema, what's erythema mean?
Red?
What?
Is it red?
Red. Turns red. And we'll often see nodules. You can see bone lesions. Once again, these sometimes will burrow into the bone. Our immunophenotyping is going to be CD3 and 4. The large lymphocytes with the flower-type nucleus. It looks like an open flower, like petals. Bless you. And these, by the way, guys, are definitely the zebras. We don't see these guys often. Cutaneous T-cell lymphoma, CTCL. It actually goes in a couple of stages. The initial stage is called mycosis fungoides. And like I said, it's skin. You'll see the patch stage where it's superficial, pretty much just on the epidermis. And most of the time, this particular one is found by dermatologists because people go in because they've got itchy plaques or scaly spots. The plaque stage is where it starts to get deeper, so it's not just on the outside of the skin, but it's actually burrowing down into the epidermis, or through the epidermis and into the dermis. The tumor stage is when it actually gets through the skin and down into the tissues, and then this progresses to a systemic Sézary syndrome. The cells are small with cerebriform nuclei. They look brain-like. Okay. They look like little brains. If you look very closely, you can see the cleft here. I've got some better pictures that we'll pull up later. Okay. Basically, they're going to be very similar to adult T-cell lymphocytic leukemia, but they're going to be CD25 negative. I'm not going to ask you the CD arrangements on these T-cell ones. Okay. Sézary syndrome, this evolves from those T cell infiltration on the skin. We're going to see erythroderma, in other words, we're going to have reddening of the skin. Generalized lymphadenopathy, it starts to invade all of your lymph nodes. We're going to see a dissemination of clonal T lymphocytes in the skin, in the lymph nodes, and eventually in the peripheral blood. This one is usually found by biopsy first. By the time it gets to your blood, it's fairly advanced. Hodgkin's lymphoma. This one is about 1/3 of all lymphoproliferative cases. So this one is fairly common. We're going to see, the big one here, we're going to see Hodgkin's Reed-Sternberg cells. They used to be called Reed-Sternberg, and then Hodgkin's got his name on there somehow. Okay. But the Reed-Sternberg cells, we'll see those in the lymph tissue or in the bone marrow, and I have pictures of those. It tends to affect younger adults, mostly under 30. This is one that we commonly see in 20-year-old males, 25-year-old males is probably the most common demographic we see around here. A lot of times, you basically come in for what appears to be just a viral infection. You'll have cervical lymphadenopathy. A lot of times they think they have mono, or they feel like they have mono. Fever, night sweats, unexplained weight loss. For some reason, we see an increase in eosinophils. Why? I don't know. But if you're doing a case study and they've got eosinophilia, and it looks like they've got a high, if they've got a lymphocytosis, it might be something to kickstart your brain. The biggest problem with this is you're at severe risk for secondary malignancies. We subclassify Hodgkin's, and all I'm going to ask you to know in this basically is what the names of them are and which ones have Reed-Sternberg cells. So our lymphocyte-rich one has Reed-Sternberg cells. And that looks like about it. Classic Hodgkin's lymphoma is again associated with Epstein-Barr. Most of the cases are is nodular sclerosis. If the lymphocyte risk category, this has the best prognosis. They can get it into remission. The problem with, especially with the lymphomas and Hodgkin's in particular, it keeps coming back. You get it into remission, you're fine for a few years, you get run down, and bugger comes right back. Then they get it into remission, you're fine for a couple of years, and then it comes back. So a lot of times, and it may not always come back as the same kind. It may progress through and become something different. When you hit lymphocyte depletion, the thing about this one is the strong association here is Epstein-Barr virus in patients with HIV. The combination of having mono and AIDS is very bad. It often leads to this lymphocyte depletion lymphoma, which is fatal most of the time, but it is also very rare. You do need to know how to stage Hodgkin's. This is more important than knowing what type it is, at least for our purposes. And we stage it basically by how much of your body is affected. Stage 1 is a single lymph node. Okay, there's one little piece somewhere that's got these abnormal cells. Stage 2, we see more than one lymph node or more than one area, but they're on the same side of the diaphragm. What does that mean? The same side of the diaphragm. Right, it's either up top or it's down below. In stage 3, we spread and we are both sides of the diaphragm. And stage 4, that's when we start seeing it invade the peripheral blood and the bone marrow. That means it's pretty much systemic, and that's going to be obviously the most difficult to treat They have over an 85% or 80% survival rate. If you happen to catch it at stage 1, just, you know, if you go in with a lymph node, either cervical lymphadenopathy, or a lot of times, again, swollen lymph nodes in the armpit and in the groin are a common cause for people to go to the doctor. And if they biopsy it and find this before it has spread, they've got a better than 90% chance of curing it. But like I said, it does have a tendency to be rather persistent. I won't say aggressive because that's not the word, but it is persistent. This is a Reed-Sternberg cell. Okay? And depending, it either looks like googly glasses or it looks like boobs. Whichever one makes you remember it, go for it. We actually had a girl got a t-shirt probably 2-3 years ago. She still works in this area, so I won't say her name. But she had Reed-Sternberg on the t-shirt. But they are very distinctive, binucleated. They look like two cells hooked together, but there's a very distinctive look to them. We're not going to see those in the peripheral blood. We're going to see those most commonly in a biopsy of the lymph node or of lymphatic tissue. And we will sometimes see those once we get up here to stage 4, we will find those in the bone marrow. You are not going to find these in the peripheral blood. So if I tell you it's a peripheral blood picture, don't tell me it's Reed-Sternberg. Oh boy. We are done with white cells. Yay. Some people love white cells. That makes more sense to them. Some people love red cells. That makes more sense to them. Some people get both of them, and some people, none of it makes sense. So the lymphomas, when we go for them, I'm going to ask quite a few questions on CLL and SLL. Why? Because it's the most common. I'll probably ask quite a few questions on Hodgkin's. Why? Because it's the most common. The aggressive T cells and NK cell lymphomas, very basic. I'm going to stick to very, very basic questions on those. We have to put our resources where most of the test questions are going to come from. Oh, Lord. So, any questions on lymphomas? What's the difference between leukemia and lymphoma?
Site of origin.
Site of origin. Okay, so now we start hematology part 2.
I'll return in a second.
I'll print off like 8.
Do we need to print some of these out?
I'll do a bunch.
Yeah.
What is it, erythrocyte production?
I tell you what, if it prints out, print one, and if it has a line, if it's not printing well, let me know and I'll run down to the office and print it.
No, we just printed them.
It's not printing well?
No.
All right, well, I'll tell you what I will do. Why don't we take a little break, okay? We might as well, between white cells and red cells, we'll give ourselves a refreshing little brain. She says it's not printing, so I'm gonna run down to the office. I will print it out, and how many do I need? 1, 2, 3, 4, 5, 6, 7, 8. All right, what format am I printing these in?
6.
You like the 6 slides?
Horizontal.
Horizontal 6 slides. I will be right back. You all can feel free to get up and move about. Beat them into submission. No. $100,000 instruments. I can troubleshoot those. Staplers, throw in the trash can.
They're not worth troubleshooting at that
They're
point.
not worth troubleshooting, exactly. Okay, erythrocyte production. We've been talking about leukocytes, white cells all along. We're going to go on to the erythrocyte. We're going to study much more in depth how it functions, not just that it functions. The leukocytes, there's so much that I can tell you about how the granules work, and in fact, we talk generally about phagocytosis and stuff. But with those, there's plenty to hang on to without actually getting into specific function on all of them. The erythrocyte, we kind of need to understand how the hemoglobin molecule works in order to be able to diagnose and treat patients who have a variety of anemias. So hematopoietic development, while technically refers to all blood cells, here we're using it to just basically talk about red cells. It actually begins at about 4 to 6 weeks gestation. So just over a month after the fertilized egg implants, we start to see a little bit of hemoglobin produced in the blood islands of the yolk sac. So before it really is even, differentiated into anything, we start to see a little bit of hemoglobin-like production. After about 5 weeks gestation to just before you're born, what we see is that the liver is our primary site of blood production. This is very important when we're talking about preemies, because a lot of times our premature babies, their blood production is still in this hepatic stage if they're young enough. The liver, we're going to see some splenic involvement. There'll be some hematopoiesis in the spleen. We refer to any time that hematopoiesis occurs outside of the bone marrow, that's referred to as extramedullary hematopoiesis. And that term's going to come up over the next couple of weeks in reference and in conjunction with certain other anemias, etc. So just like when we talked about CML, we're going to see extramedullary hematopoiesis there eventually. We move right before we're born, we move into the medullary or the myeloid phase, where bone marrow becomes the primary site. By the time you're about 6 months of age, you are no longer having any hepatic or splenic involvement whatsoever. By the time you're adult, production is limited to the flat bones and the ends of the long bones. The Rodak book that we used to use, I didn't find it easy to read, which is why we switched to Mackenzie. They had some killer pictures, so I made sure to steal those before I moved on. Basically, this is where we see hematopoietic development. What does it mean? I've got lots of nice, lovely lines and things. Yolk sac, hepatic phase, medullary phase. In a child, notice that pretty much all of the marrow is red. So you have additional blood formation pretty much throughout the entire body. Once we hit the adult stages, we're only going to be seeing it at the ends of the long bones, in the flat bones, including the pelvis, the sternum, and the skull. It's sort of moved back out, away to just the ends, and then the central portion of the bones just becomes one more place to store fat. Why do we like to raise our bone marrows? Or why do we like to raise our hemoglobin in the bone marrow? There are many things about the bone marrow that make it conducive to the production of red cells. If you think about the circulatory system as a river, well, the bone marrow is kind of the marsh. The blood does not move through it very quickly. It's like it rushes in and then it just sort of slows down and oozes through everything. Because it's moving so slowly, we're going to see increased CO2 levels. And HCO2 is a weak acid. So as CO2 rises, we're going to see a decrease in the pH. And our red cells like to bathe and like to grow up in a slightly acidic atmosphere. It facilitates some of the things that have to be done. There's a sticky surface due to the multi-layering of cells. Again, think of it like a marsh. There's lots of little floaty islands where they can kind of get in the little nooks and crannies and sit there and be safe from the water rushing them away. The monocytes are going to transform into macrophages, and here they are not only gobbling things up, but the macrophages actually present the iron to the hematopoietic stem cells. So they're kind of regurgitating and giving back in this case. Again, a place to anchor means that the stem cells can grow because they're not having to kind of fight. The cell bed helps to foster differentiation and the development of the specific cell lines needed. Erythropoiesis occurs in the central sinus beds where the iron-leg macrophages are easily accessible. In other words, it's going to be in the bigger pockets. Once again, we're back to this slide, cut and paste, it's the same one we had earlier. We have the pluripotential stem cells, the progenitor cells, and we are back to the CFU gem. We're specifically looking at the E portion of it, which is our erythrocytes. But remember, it is from the myeloid line, which is our granulocytes, our monocytes, and our megakaryocytes. Lymphocytes are kind of the weird cousins that nobody wants to claim. What do you need to remember about cytokines? The same thing we remembered last time, which is what? They exist and they regulate hematopoiesis. That's about all I know about them. For my test, I'm not saying they won't show up on the boards. We talked about bone marrow aspiration and biopsy. You saw the picture of the guy and where his hematopoiesis occurs, and you notice a lot of it's in the hip. Why would we want to go to the hip instead of the sternum?
So you don't miss.
Yeah,
Hit
I've
hard.
actually, they used to do bone marrows in the sternum all the time.
There's a
And
higher
I've
chance of error.
seen, huh?
There's a higher chance of error up there.
Yeah, I'm just like, oh man, because I've seen them go at that hip, and I'm just like, you could poke something, and there's like really important stuff back there. Or the skull, I don't think we're going to the skull either. Why do we go to the hip bone? Well, there's just not as much risk. And your sternum's only about yay thick, and the needle we get it with is 2 or 3 inches. I'm like, you could just go right through that. Besides that, I wouldn't want to be laying there watching the doctor. I'd rather be face down. Have no idea what's going on behind my back.
You said you've seen that history?
I seen a sternal, yeah. It was, yeah. I mean, they put a cloth over the lady, you know, between the, you know, like
No, I don't
a,
understand.
like they do when they do a C-section, you know, the drape so that you can't see what's going on. But that's still,
Was she alive? I mean, like.
Wait,
No, you know.
she was conscious, yeah. They don't put you under for it. They just gave
They
her a
don't?
local, yeah.
Oh, no.
She was very vocal. I'll just say that. What do you know it? Anyway, so what we're going to evaluate when we look at the bone marrow, we're looking at cellularity. There should be just about as much hematopoietic marrow as there is fat. There should be a nice equal ratio between the two. We should see somewhere between 2 and 4 times as many white cell precursors as we do red cell precursors. There should be adequate iron stores, and we're going to do that just by staining it with Prussian blue and looking for iron. And we should see a normal distribution of the cells. There are normal ranges for what we see in a bone marrow, just like there are normal ranges for the peripheral blood, which some of you still need to learn. Erythropoiesis is the formation of red cells. The erythron, which is not a term we use a ton, but I have seen it in literature a couple of times, and I've actually had to go look it up. But basically, that's all of the erythrocytes and erythrocyte precursors you have everywhere. That's all of your red cells and what could be red cells. After the gem, the CFU gem, we move into the BFU, or burst forming unit, erythroid. And then that goes down into the colony forming unit, erythroid. What do you need to know about that? That's it. Factors influencing erythropoiesis. These I do want you to know. Don't just kind of glance past these. Erythropoietin is very important. It's a glycoprotein produced by the kidney in response to hypoxia. What is hypoxia? A lack of oxygen. What does it cause if you keep producing erythropoietin? and you don't have true hypoxia, what happens? Secondary polycythemia. That's why this one's kind of important. The other reason that this particular cytokine is important is that we actually can synthesize this little baby. And when we are treating our leukemias, what are we doing? We're wiping out the bone marrow. So you're going to become anemic. Rather than transfuse these patients, many of them respond better. What we can do is we can just give erythropoietin, which goes to the bone marrow and stimulates just the hematopoietic cells, just the erythro precursors. So just red cell production. EPO's it's known as EPO. It's very expensive. I think it's between $5,000 and $10,000 a shot. But it works a lot better than having to go in and get transfusions, and it's a lot less risk. It does not work for everyone. They also give it to a lot of times adrenal patients with renal disease who have consistently low hemoglobins. We used to transfuse our renal patients almost every time they were on dialysis. With the advent of better dialysis and some alternatives to transfusion, we're down to transfusing a lot less. Testosterone. Why is there a difference between male and female ranges, which, as you all know or should know, there is? The reason is because testosterone is a potent cytokine for red cell production. So men naturally have a higher red count. Nutritional status, and this is really huge when we're talking about the anemias. This is going to be our #1 place we're going to start for why are you anemic. Okay, if you're not bleeding out on the floor, then we're going to have to figure out why are you anemic. And the first place we start is iron and B12 and folic acid. These are our most common anemias. In fact, we'll do 2 whole PowerPoints on this one and a whole PowerPoint on that one all by themselves. That's how often we see them. I never can say this plastic word. Apoptosis. Butchered too bad this time. It's programmed red cell death. What does this mean? Pretty much as soon as a red cell is born, it is going to degrade at a fairly specific rate so that you can pretty much tell when it is going to die, which is about 3 to 4 months after it's formed. Why is this important? Because if we have an increase in cell death, we're going to have anemia. And there are some anemias that will fall into that category. Normoblastic maturation. Normoblastic maturation. Basically, it's just like our white cells. There are multiple steps in this one, more like the granulocytes than like our monocytes. Once the blasts are committed to erythropoiesis, they'll produce nucleated red cells, which should be only seen in the bone marrow, but we do know we see them outside the bone marrow once in a while. As the red cell matures, we're going to see an increase in intracellular hemoglobin. That's the whole purpose for the cell, right? So we're going to make more and more hemoglobin. We're going to see a resultant cytoplasmic RNA decrease. Okay, this is a tough question for you. How do I tell that there's a decrease in RNA? What am I going to see on the slide? Well, the nucleus is different. What am I going to see on the slide that tells me that there's less RNA? What color are my cells going to be?
Blue.
They're going to go from blue, which means there's a lot of RNA, to red, which means there's no RNA. Okay? So we're going to see a change in color. So young red cells are polychromatophilic. In other words, they're blue. So those poly cells that we see, the ones that are blue, they're very young. The chromatin is going to condense, and it's going to condense to the point where it's just a blob. Pretty much it's garbage in the last step before the red cells are released into the circulation, is it spits out the nucleus. That's the last step in RBC maturation. Basically, if I take one stem cell, it takes me 4 or 5 days, and I'll get between 8 and 16 mature red cells. Yes?
You said it's spitting out the nucleus, it doesn't digest it?
No, it just spits it out.
What happens?
It gets eaten by macrophages and taken back for recycling. The lifespan of a red cell is about 120 days, which is why when we talked about pancytopenia, we talked about what disappears first when you have pancytopenia coming, which is a reduction in all cell lines. Which cell line disappears first?
Red?
If I'm going to see a reduction in cell lines, which one disappears first? Platelets. Why? They get used up the fastest. Then we're going to see a decrease in white cells because they get used up the second fastest. We won't actually see anemia from bone marrow failure for quite some time, actually up to a couple of months. Yes?
What's platelet and white blood cells like?
Platelets, I believe, are 5 to 7 days, if I'm correct. White cell, it depends on exactly which type of white cell it is, but it's in the days to weeks range. Lymphocytes live a little bit, or they last a little bit longer. Monocytes last a little longer. Neutrophils, not quite as long. Unfortunately, people can't agree. They renamed all of the precursors, but some of the old people wouldn't let go of the old name. So you will see both sets of nomenclature pretty much equally represented in the literature, which means you've got to know them both. Which means this looks like a matching question. We have the rubroblastic, and then we have the normoblastic maturation. Our pronormoblast or ruboblast is the youngest cell that we can identify as an erythrocyte precursor. But it's just a blast. Now this one does have a little bit different look to it, and we'll go through each one individually. Then we move on to the prorubrocyte, which is the same thing as a basophilic normoblast. Then we have a rubrocyte, which is the polychromatic normoblast. Then the metaruberocyte, which is the orthochromic normoblast. The reticulocyte and the polychromatophilic red cell, these basically don't necessarily go in line with that, but we will see them called both of these things. And then we have a mature erythrocyte. The only way I remember these, and when I was doing nervies yesterday, I actually had to stop. I have to go down each side. I've memorized each one, and then I got to match them up that way. I can't ever remember them any other way.
Which one is the new name?
The newer name, I believe, is the is the normoblast. They're both used equally, and like I said, so you got to learn them both, and you've got to be able to match them up, and I will use them both interchangeably.
What's your ratio there?
The NC ratio,
Yeah.
the nuclear to cytoplasmic ratio, is going to be about, the nucleus is going to be about 8 times as much as the cytoplasm. And then the cytoplasm is going to increase. So here we go. Our blast is the earliest recognizable red cell precursor. These will be eligible for picture tests, but not this week. This week, if you see a nervy, what are you going to call it? Nervy. NRBC, nucleated red blood cell. And please don't spell nervy. Somebody spelled it like N-U-R-B-E-Y. No, that's not a real word. It's a dying word. These are going to be fairly large. They're going to have a round, maybe slightly oval nucleus. The erythroblast is one that actually, even I can tell that versus a monoblast. It tends to have a really, really scant and really, really dark blue cytoplasm. You're still going to have a very fine chromatin and probably a nucleoli. The prorubrocyte, and once again, remember these things just like when we're talking about the maturation of the granulocytes. These aren't like magical steps. Poof. They're like children, you know, toddler, child, preteen, teen, adolescent. The stages are not like defined, poof, they change one to the other. They sort of slowly grow through them. The chromatin is becoming slightly coarser. You may start to see the nucleoli disappear. And the cytoplasm is going to remain a really dark blue, but we're going to start seeing some hemoglobin production right next to the nucleus. So we may see a slight dawning area, kind of an area where it's just starting to get pale by the nucleus. That's where we're seeing a beginning of the hemoglobin production, or at least setting up for the hemoglobin production. The ruberocyte or polychromatophilic normoblast, it gets smaller. Hemoglobin production is evident, and how is hemoglobin production evident? How do we tell it's starting to make hemoglobin?
It's starting to turn pink.
It's starting to turn pink. So it's actually going to go through kind of a purple color at one point. Okay. So we're going to see the mix of the blue and the red. The cytoplasm, I think I need to fix that. There should have been something else there, resulting in a grayish cytoplasm. I think I need to get rid of one of those enters. The chromatin is going to be moderately condensed, and the proruberocyte, that's the one I said, to me, the chromatin looks like it's wormy. It's like little worms, like little ball of worms. The metaruberocyte, or the orthochromic normoblast, it's going to be slightly larger than your normal red cell. The hemoglobin is definitely apparent. We're going to see much more of a red color, much less of blue. The nuclear chromatin is pycnotic, which means it is just absolutely dense. It's basically just been crushed because it's not functional anymore whatsoever. Okay? And it's ready to be extruded. In other words, it's going to spit it out. If you have someone who has a lot of nucleated reds, as you're going through, you may very well find some of these nuclei just floating around unattended. Usually somebody goes, is this the lymph? No, it's nucleus from memory. So somebody will ask the question, and it's a good question, it's valid. The polychromatophilic RBC is also known as a reticulocyte. They're a little bit larger than the red cell. They do not have a nucleus. Retics do not have a nucleus. Somebody's gotten confused on that before, so I'll make sure I'm clear on that. We're going to see some residual RNA. We're going to see a bluish tint to it when we're looking at it on the slide. When we stain it with a supravital stain, such as new methylene blue, which is what we use, this is what we get. Our reticulocytes are going to retain some of the reticular endothelium, i.e. the name retic. So we're going to see a little bit of strands of RNA in here. This is where the hemoglobin production occurs before the nucleus disappears. Those are reabsorbed and broken down pretty quickly after it is released from the bone marrow. Then we have the mature red cell. We're going to talk a lot more. We are going to do a reticulocyte test. We'll do that next week. We're going to stain and we're going to count retics. A lot of times I try to refer to, I use analogies. You've all figured that one out. And I've talked all about, kids growing up and stuff. If you think about your retics, when a family is wealthy and doing well, when do the kids finally leave the house? When they're stable, secure, they're through school, they're ready to go out into the world. If your family's not doing so well, and there's an economic downturn or something happens, you're going to take them teenagers and you will tell them get off that couch and get out there and find themselves a job, aren't you? You need to start producing. If things get bad enough, you're going to tell the little kids, go see if somebody will let you carry their trash out to the curb, or see if you can go make a lemonade stand. That's how I think of red cells. Okay? If you have only nice, mature red cells in your circulation, your bone marrow family is doing well. It's in good shape. It's fine. It can wait till the cells are totally grown up before it kicks them out the door. If you start seeing a lot of retics, means they're not doing so good, and they've had to kick the lazy teenagers out and make them get off their butt and get a job. And if you start seeing the nucleated red cells, they're sending the little kids out anything that will carry any amount of hemoglobin, any kind of resource that they can. The mature red cell, we've already talked about it. It's about the size of a lymphocyte nucleus, and it's the biconcave disc. Yes?
So a retic is or is not like a normal part of the maturation phase?
It is a normal part of the maturation phase, but you should only see it really in the bone marrow and a small percentage circulating in the peripheral blood. Okay. You know, there's always going to be some go-getter teenagers who are going to go out there and get a job, even if their family's doing well. But for the most part, they're going to be lazy, stay home, and let mom and dad take care of them for a little bit longer. So you'll see a few retics in a normal peripheral smear, up to I believe about 1%. But when we start seeing increased retics, it means that there's a stress of some sort on the bone marrow. Now, it may be something as simple as females have a slightly higher retic percent. Why? They lose a little bit of blood every month, so the body has to account for that. Or maybe you were sick and you didn't get all your nutrients like you should have, so you got a little bit anemic, and as the body recovers, we're going to see an elevated retic. We're going to use this retic a lot when we're trying to decide, is our treatment working? So if you've got anemia and I treat it, my retics should go up. And if they don't, I got more problems, don't I? So we are going to talk about how the retic works and what we do with the retic. Any questions? This one is so simple, we'll do it tomorrow. It's really easy. We're going to do differentiating anemias tomorrow. You guys are really doing well in lab, and I think we're actually on course with lecture, which is unusual. Usually I'm behind somewhere. I want you to finish the normal diffs today. I have 5 of them available. I'm going to be sitting up at the front of the room, going through slides, trying to find, I have a database I created that has all the answers in it, and I can't find the current database. It used to be on the lab computer, and I don't know what IT did, but it's gone. Everything I've put in for the last 3 years is missing. So sometime in the next couple of weeks, I have to find time. Hopefully it'll be quiet tonight, and I can just sit at work and count those, because I can get through them pretty quick. So I'm going to be counting more diffs than you guys, but I'm faster. And I cheat, I use the electronic cameras. My fingers don't work so bad. Once you have finished your 5 normal differentials, and we are going to go over how to tell if they're in range or not. Once you finish that, we're done for the week. So if there's any of you who need to retake a test, if there's any of you who need to get some other stuff done, if there's any of you who want to do some one-on-one diffs, I'm kind of thinking Thursday I might have Melissa go through and do a diff with you. She's trained by me, so she's got the same basic information that I've got, but maybe having her do one with you would make a little more sense. Right? Maybe I'm getting a little too far away. But I'll have her do one with you so you can question her, and we'll see if maybe that helps with your understanding. Next week I want to start on slightly abnormal diffs, which means probably some morphology. A couple of you, I know you did the sickle, or who else did the sickle cell diff? Sickle cell, was it? Yeah, the one that had a little bit funky morphology. That was a sickle cell patient. I'm not counting morphology this week, so it doesn't matter. I got the morphology one plus. You got that the morphology was not normal. That's all we're looking at this week. Normal, not normal. It's sort of like this week we're looking at bands and sags, that's our neutrophils, and we're looking at lymphs and ATLs, that's our lymphs. And as long as those combined numbers match, we're good to go. Starting next week, we're going to diverge those to make sure that you're pretty much staying on course. Okay. And I can't find, I told you, finding a perfectly normal smear, I haven't got one yet. There is not a single slide anywhere that I have that is perfectly normal. There is always that one cell, it's, oh, I think I got it. What's this? You're gonna get an ATL, you're gonna get a band, you're gonna get something that's just. All right, so you need to give me about 15 minutes because I gotta count those 5 slides. But if you wanna get set up to do those, if there's anyone who needs to do wet work, who needs to do, like counts, if you've still got a CBC to do or something like that, let me know and I will bring bloods from work tonight. So we have those for tomorrow. For today, you don't need safety gear, you don't need lab coats unless it's cold in there. You don't need gloves because stained smears are not considered hazardous. Make sure at the end of the day though that if you are doing wet work that you're taking like the antibiotic wipes and wiping down your scope, because otherwise then when you're doing slides which are not biohazardous, well, you don't know what's on your scope. So, but that's why you each have your own scope so that you don't have to worry about somebody else having contaminated it. Okay. I'll see you in there in about 15-20 minutes. Or 5 minutes, or now, whatever. The shirts are in a big box, so if you guys want to start rummaging through those.
Yeah, I did too. I know my t-shirts were navy and the previous one. I don't remember what the sweatshirt was.